Good morning, dear audience. First of all, I would like to introduce myself. My name is José-Pablo Tirado-Pérez. I'm from Spain. I am currently doing my clinical practice as a dermatologist at the Virgen Macarena University Hospital in Seville. Today, I would like to present the following study that I carried out during my stay at the Department of Dermatology, the Whatu Health, New Zealand, at Waikato Hospital. Before presenting the study, I would like to thank the International Society of Teledermatology for giving me the opportunity to present this work to all you. I would like to mention two key people in my professional career as a dermatologist, Dr. Amanda Oakley, who was my mentor during my stay in New Zealand, and Dr. David Moreno, head of the dermatology department in Seville, who is constantly supervising my training. Having said that, let's start with an introduction to the subject. Worldwide, the incidence of cutaneous keratinocytic cancer, which consists of basal cell carcinoma, or BCC, and cutaneous squamous cell carcinoma, or SCC, is high and increasing. Some countries, such as Australia, have the highest incidence in the world. However, the true incidence is difficult to describe because many cancer registries do not record this type of skin cancer. The New Zealand population has one of the highest incidence of non-melanoma skin cancer. Older ages, fair skin color, and exposure to UV radiation appear to play a major role. According to the Health Promotion Agency, it's estimated that more than 70,000 people were diagnosed with invasive skin cancer in 2013, and 80,000 people are expected to be diagnosed in 2018. These high numbers of keratinocytic cancer are putting pressure on healthcare system, and the economic burden of keratinocytic cancer is significant. With the occurrence of COVID-19, dermatology departments around the world, often with few dermatologists and located in urban centers, have rapidly adopted teledermatology, improving our understanding of teledermatological assessment of skin disease. With the right equipment, such as the dermoscopic camera, a picture archiving and communication system, and a large high-resolution monitor, teledermatology can offer excellent cancer detection with reduced waiting times, fewer biopsy, and fewer non-essential visits to the dermatology clinic. In countries such as New Zealand, Australia, or UK, the general practitioner or GP has a gatekeeper function and decides on the diagnosis, treatment, and referral of skin cancer. This role is essential in many countries because of the potential for cost saving and reduction of specialist waiting times. However, their surgical skills may vary considerably due to a variety of factors, and significant differences in the surgical outcomes may occur between GPs and specialists. Determined to shed light on this issue, we conducted the next study, surgical excision margins in primary care and plastic surgery for keratinocytic cancer diagnosed by teledermatology. A key to comparing surgical and oncological results is the assessment of the distance from the tumor to the lateral margin of the specimen. Thanks to the detailed histopathological report, we have been able to determine lateral and deep margin. We use plastic surgeon as the gold standard for surgical performance, as few dermatologists in New Zealand focus on surgery. All excited lesions were previously assessed by teledermatology, where the dermatologist confirmed that excision was necessary. When faced with a suspicious skin cancer, GPs can fill out an electronic referral template for both evaluation and excision recommendation. They must include demographic and clinical information such as location, size, evolution time, and diagnostic suspicion. They must also provide 3 images: regional, close-up, and dermoscopy image. The final sample was selected using the following flowchart. In the period of March to May 2022, 322 electronic referrals with 390 lesions were received with code C449. This code is used when keratinocytic cancer is suspected. However, 32 lesions were wrong code and 8 lesions were treated not surgically. Missing data after excision recommendation occurred in 46 lesions. Finally, 267 excisions were performed by GPs or plastic surgeons. As a result, we obtained 201 confirmed keratinocytic cancer from 267 excisions, of which 186 tumors showed complete excision. However, 50 lesions showed incomplete excision, with lateral and deep margin involved in 10 and 8 tumors, respectively. GPs were responsible for all incomplete excision, being 11 lesions located on head and neck territory. On the one hand, we found 133 basal cell carcinomas. 75% of them were excised by general practitioner and the rest by plastic surgeon. 40% were located on head and neck territory. Interestingly, the 20% located on head and neck were excised by general practitioner. Other frequent locations were back, arm and hands, and torso. This graph shows the lateral margins left by the GPs and plastic surgeon for BCC in their performances. The blue color represents excision less than 3 mm, so there are clinical differences between the two groups, which are more positive for general practitioner. The data also shows statistical differences. This means that general practitioners tend to leave less than 3 mm lateral margin when they excise compared to plastic surgeon. In other words, BCCs excised by GPs were 2.87 times more likely to have a margin of less than 3 mm than those excised by plastic surgeon. On the other hand, we found 68 squamous cell carcinoma. Of these, 84% of them were excised by general practitioners and the rest by plastic surgeon. The 30% were located on the head and neck area, and again, the 20% located on the head and neck were excised by general practitioner. Other common locations were photoexposed areas such as the arms and hand and lower leg. We contrast the same graph for SCC. In this case, the threshold has been changed to 4 mm. Again, the blue colors represent excision below the 4 mm, so there are clear clinical differences between the two groups, being more positive for general practitioners. However, this data did not show statistical differences, probably due to the small sample size of SCC. When reviewing the literature, our results can be discussed with other studies. For example, this systematic review, published in the Journal of Cutaneous and Aesthetic Surgery, analyzed the complete excision rates. It can be inferred that dermatologists excise skin cancer lesions more adequately than GPs and plastic surgeons. Unfortunately, this group does not exist in our study. However, we can conclude from our study that GPs achieve a higher rate of complete excision compared to others studied, but that they removed fewer lesions located on the head and neck territory. Now, looking at this meta-analysis published in the British Journal of Dermatology, it analyzed the incomplete excision rate in this case. Based on the comparative data, plastic surgeons and GPs in our study achieved a lower incomplete excision rate than the others, with none case for plastic surgery or around 10% for general practice for BCC and SCC. However, most of studies focus on the complete or incomplete excision rate, but few of them analyze the distance between the resection margin. And comparing the few studies that focus on lateral margins, I would like to discuss this one with you. This study was carried out in an Australian hospital. The researchers performed a retrospective analysis of low-risk keratinocytic lesions located on head and neck territory. These lesions were excised by ENT surgeon. In total, there were 18 SCC and 50 BCC. Looking at the SCC, 8 out of 18 SCCs are below the 4 mm recommended by international guidelines. Looking at BCCs, 26 out of 50 BCCs are below the 3 millimeters recommended by the guidelines. This data could be justified because of the head and neck location. But if we set a distance between the tumor and the lateral margin, we remove the lesion with that safety margin, we put it in a transport medium such as formalin, and then we analyze that distance under the microscope, what happens? We might think that this distance has changed. Well, the literature shows that a specimen shrinks up to 17% from its excision to its histopathological analysis. It is assumed that both the tumor and the peritumoral tissue shrink proportionally, so the distance between the tumor and the lateral margin could still be useful. Interestingly, more than 80% of the shrinkage occurs in the first 5 minutes after removal of the specimen, not including the piece in formalin. The authors theorize that this is due to the continuity solution produced by the scalpel on the collagen and elastic fibers. The arrival of artificial intelligence is a reality. Many computer systems are being studied to improve diagnostic accuracy, decide on the most appropriate treatment, and give an accurate prognosis. On the slide, you can read some of these tools that have already been mentioned at the World Congress of Dermatology this year. However, we're still a long way from implementing these technologies in our daily clinical practice. Meanwhile, teledermatology in New Zealand, understood as clinical communication between general practitioner and dermatologist, adequately fulfills this function. General practitioners play a major role in teledermatology and skin cancer surgery. On the one hand, their role is to identify suspected skin cancer lesion and refer clinical and dermoscopic image to the dermatology department. On the other hand, once the dermatologist has recommended excision, they can carry out the excision. As already mentioned, they performed the most of the excision, being the technician who performed the most low-risk skin cancer surgery, demonstrating that GPs could reduce the long waiting list for surgical excision in hospital. As a note, general practitioners develop the activity under the private sector, so the excision could incur cost to the patient. To determine the threshold for the lateral surgical margin in our study, we look at the recommendation of international guidelines for the management of skin cancer, using in all cases the closest recommended threshold in order to be more restrictive in our conclusion. In the case of basal cell carcinoma, the most recent guideline recommends a minimum safety margin of 3 mm for low-risk BCCs. For high-risk BCCs, 5 to 50 millimeters should be chosen. For squamous cell carcinoma, the British Association of Dermatologists and the European consensus-based guidelines recommend a minimum safety margin of 4 and 5 millimeters for low-risk SCC, respectively. Some limitations of our study are missing or ambiguous data related to the retrospective design and the small sample, especially for SCC, where with a larger sample we could already find existing clinical differences and probably statistical significance. It remains to be seen how many BCC and SCC would have recurred based on the surgical margin. This could be a future study. Finally, we conclude that in our study, general practitioners were less likely than specialist surgeons to respect surgical margin recommendation established in international guidelines for managing keratinocytic cancer. Here are the references that I have used to prepare this presentation. Thank you very much for your kind attention.